At OnlineMedEd, we walk you through every topic in detail, so you're ready for the boards and the wards. Psychotic disorders are going to be primarily schizophrenia and its variants. So we're going to spend a lot of time in this lesson about schizophrenia, a little bit about its treatment, and then how you modify the name based on the duration of symptoms and whether or not mood disorder is present. Psychosis is a thought disorder, so it's more than delusions. But what you're going to see is predominantly the delusion. So a delusion is a fixed false belief. A bizarre delusion is a fixed false belief that couldn't possibly be true. The problem is that bizarre is going to depend on your culture. If you live in the United States and believe that physics is truth, then you may look up at the stars at night and believe that there are balls of gas emitting light from light years away, and we're seeing light from 10 million years ago. Which, if you told that to somebody who didn't believe your physics, would sound pretty bizarre. But you consider that truth. So someone else may have a cultural difference that believes that those same stars that you believe are light are simply fairies. They're communicating to us. So it's not enough anymore to say that a delusion is bizarre. That diagnostic criteria is out. You must have sufficient diagnostic criteria to make it fit schizophrenia. Otherwise, it may not be a disorder at all. Delusions, fixed false beliefs, bizarre delusions can't possibly be true, but that can't possibly be true because its variable on culture is no longer heavily relied on. So what I want to do is start off with schizophrenia, learn a lot about that, modify it, and round off the lesson with some of the highlights of treatment, knowing that we're going to get into the pathophys in the farm psych lecture. Start off with schizophrenia. I promise it won't be that bad. All right, we know that schizophrenia is a thought disorder. And we also know that it is a genetic component. We don't exactly know what the gene is, but we do know that those who are identical twins have a significantly increased risk of developing schizophrenia. Usually, it is the disorder of a mind that is predisposed to schizophrenia following a sufficient stressor. See how that becomes relevant in the middle of the lesson. But schizophrenia consists of both positive symptoms, those things that are there that shouldn't, delusions, hallucinations, and we believe that this is caused by an excess amount of dopamine. You can see psychotic features like hallucinations if you treat someone with Parkinson's with dopamine agonists. You're trying to restore the movement portion of the brain, but you're giving dopamine everywhere and you may precipitate hallucinations or delusions. There's also negative symptoms. These are the things that should be there but aren't. And we believe that these are caused by an increase in serotonin. Now, I'm not getting down to the subtype or the location. We will do that in the psych farm lesson. I just want you to see that where I want you to lock in one-to-one, positive symptoms, dopamine, negative symptoms, serotonin, and it may not be wholeheartedly truthful. It just happens to be that's how the medications have turned out. Typicals cover dopamine, focus on positive. Atypicals work on both dopamine and serotonin and end up treating positive and negative symptoms. All right, enough of warm-up. Let's talk about the diagnostic criteria for schizophrenia. You must have at least 2 of the 5 we're about to list, and 1 must be from 1 to 3. See why that makes sense in just a second. And I'm going to break them down into positive symptoms and negative symptoms. You have to have 2 of the 5, and any one must come from 1 to 3. So number 1 are the delusions. The delusions may be bizarre or otherwise, but what you're looking for in these delusions, there's going to be 2 major ones that are going to predominate. That is persecution or grandiosity. Someone's out to get them, or they're bigger than they appear. Number 2 is hallucinations. And schizophrenia, psychotic disorders, unlike those that are induced by medication or illness, are generally going to be auditory. And you may actually see this in a patient responding to internal stimuli. They're looking off into the corner. They're having a full conversation. They're pausing at appropriate times and responding to questions that are being asked. But you only hear one side of the conversation because the person they're talking to isn't there. They see them talking to them. They hear the whole conversation. Much like someone wearing their cell phone. You're not sure if they're talking to their cell phone or they're talking to themselves. A schizophrenia patient has no cell phone. They're talking to someone on the other side, but that person really isn't there, which can be very frustrating for patients. Right? If you ever try to have a conversation with somebody when a movie's playing, well, you like that movie. You're distracted from the conversation by the movie. Or maybe you're distracted from the movie by the conversation, but you can't attend both. That's what's happening to a schizophrenic all the time. There's a full conversation. This hallucination is talking at them, trying to have a conversation while you're interviewing them. You don't know what's going on, but they're trying to shut that person up or tune them out, but it's really hard because it's their own brain doing it. This also can lead to disorganization. And 3 and 4 are about disorganization. While you can also have catatonia, I'm going to leave it off the board because I want you to link catatonia with mood disorders. That was one of the big changes in DSM-5. There's no more subtypes. Paranoid, catatonic, disorganized schizophrenia are gone. They're simply diagnostic criteria. Disorganization can occur in the way of speech or behavior. Disorganization is fairly difficult to explain, but it's pretty easy to spot. Disorganization means you just don't do things the right way, right? You've lost touch with reality. You're doing something that's completely off the wall. The way this manifests is in appearance. People stop grooming, stop bathing, stop changing their clothes, and they stop leaving the house. If you can imagine JFK and the King of Spain, who aren't really there, talking to a college kid, telling him not to go to class, but to wear tin foil on their head to protect them from the aliens. But don't go outside, because if you go outside, the satellites will get you, and the US government's coming after you. You can imagine that that kid who's listening to JFK and the King of Spain is probably going to have a tough time making good decisions. Right? So when it's that full-blown, it's obvious. And so this is there, but it's very difficult to punctate what disorganization means in one line. The 5th is all the negative symptoms. So any one negative symptom counts, but you're generally going to see these combined. You're going to see things like flat affect, poverty of speech, or of movement, anhedonia, or you might even see cognitive impairment or cognitive delay. They weren't born this way, and when they're active, it can be impressive. You're talking at them, but they don't even engage that you're there. They have this blank stare on their face. And if they finally turn to you, they can only respond in 1 or 2 word sounds. That's not because they're gravely disabled because mental retardation, cognitive impairment. It's because their disease is active. If you treat their disease, they go back to normal. And that's the thing, though. When you see someone who's active, the presentation is almost always going to be a psychotic break. The psychotic breaks occur when medications are stopped for the first time, when they first identify the disease, and they may even have breaks through medications. Every time they have a break, they'll be left with more cognitive impairment than they had previously. So in a stepwise fashion, as they get older, schizophrenics lose function faster and will end up being demented way sooner than non-schizophrenics. The classic board question of the first psychotic break is going to occur in someone who's a teenager or in their early 20s, usually after a major stressor. And the major stressor that most kids go through is adulthood. 18, you leave the house, get a job, or you go to college. And if you see a kid with a change in behavior, the hallucinations and delusions may not yet be apparent, but they're acting weird. They're not showing up to class, and when you finally knock on their door, they've got feces all over the wall and they haven't bathed in 7 days. That's abnormal. Right? A change in behavior and a change in thought that may not be overt at first. When you see that in a college-age kid, rule out drugs, in particular cocaine. You do that with the detox. Make sure it's not intoxication or withdrawal. And when you've ruled that out, well, then what you want to do is determine the duration of symptoms and whether or not there's mood, because that's going to name the disorder and tell you what you're going to use to treat and when. The treatment is going to be with antipsychotics. Talk more about that in a bit. Where I want to focus first is on how do you name the disease, how long do you treat it. Schizophrenia, positive symptoms, negative symptoms, dopamine, serotonin. You need 2 of the 5, and 1 of the 5 needs to be delusions, hallucinations, or disorganized speech. Look primarily for persecution, grandiosity, and auditory hallucinations to separate from drug-induced or metabolic-induced hallucinations, which are usually visual. So to talk about the spectrum of schizophrenia, we're going to put schizophrenia here in the very middle of the board. If you have schizophrenia, the duration will have been greater than 6 months, and the treatment is lifelong. As you move up the board, it's going to be based on duration of symptoms. As you move down the board, it'll be about the presence or absence of mood disorder. Schizophrenia, symptoms for more than 6 months, it's not going to turn off on its own, lifelong antipsychotics. At the top of the board is going to be brief psychotic disorder, of which postpartum psychosis counts. The stressor was pregnancy, we talked about this in mood 2, and the response was psychosis. Brief psychotic disorders have a duration of more than 1 day, but less than 1 month. And the treatment should be only for a month. And then once you stop the medications, the psychosis should go away, and they won't be at risk for developing more symptoms. If it persists, chances are it's going to be schizophrenia. But you go through another disorder first, which is schizophreniform. Here, the duration is greater than a month, but less than 6 months. The treatment is 3 to 6 months, usually 6 months. The idea here, there's nothing that happens at 6 months. No, the pathology doesn't change. The point is that if they still have symptoms after being adequately treated for more than 6 months, the response is going to be, you're not going to get control spontaneously, you're going to need to medicate. That's the idea. The need to medicate is based on the name of the disorder, which is based on the duration of symptoms. It's not that at 6 months it becomes a new disease, and it's not like PTSD where if you intervened sooner, you could prevent schizophrenia from happening. If there's a stressor and someone's going to get schizophrenia because their brain is predisposed, they're going to get it. You don't know that they have it until you try them on medications, stop the medication, and see what happens. As we go down, we're going to get into mood disorder. So schizoaffective disorder is schizophrenia, duration greater than 6 months, but there's also mood. But in schizoaffective, the psychosis predominates, and there's a little bit of mood. Here, you treat the mood first. If you have mostly mood, you'll have mood disorder with psychotic features. And just to round it out, you could have mood disorder without psychotic features too, but it's not relevant for this lesson. In mood disorder with psychotic features, you got a lot of mood predominates, and you got a little bit of psychosis, maybe a hallucination or two. Treatment still mood first, and to treat mood disorders with, of course, mood medications. What's not on this list are the personality disorders which have the letters schiz in them, which confuse people. Schizoid are the loners who are happy to be alone. Generally, you don't see them because they don't seek attention. Schizotypal have bizarre thoughts and dress and magical thinking, but they're not really disorganized, and they're not delusions. And so that becomes very hard as you push somebody who's very benign schizophrenic against someone who's a really severe schizotypal, making the judgment of do you need to be medicated, schizophrenia, or not, schizotypal, becomes challenging. You won't have to make that decision. They're going to be non-bizarre delusions, and they're going to be fairly unimpaired. Whereas schizophrenic is going to be homeless, disheveled, talking to himself, delusions, hallucinations. It's going to be overt on the test. In real life, it may be a little harder to tease them apart. All right, so this is schizophrenia and its modifiers, knowing the different names by the duration and the presence or absence of mood. I do want to touch on delusional disorder, because much like schizotypal, it's hard to tell in real life. Right? A delusional disorder will be a non-bizarre delusion, and there's no impairment. And specifically what it means is someone who has a delusion but doesn't have 1 through 3. A delusion is a fixed false belief, and it may be something as simple or innocuous as the cashier who falls in love with a doctor. And he thinks the doctor's in love with him, even though all he's ever said to her is, 317, do you want a receipt? It's reasonable for 2 people to fall in love at a workplace. But to the doctor, she doesn't know who he is. So that's weird. Another example would be a gentleman from Maine who believes that Jamie Lynn Spears and he are destined to be together, star-crossed lovers. Keeps showing up at Jamie Lynn's house. Well, he keeps getting sent back to Maine. He's not violent, he's not weird, he's not disorganized. In fact, he's got a lot of money, so every time the police send him back to Maine, he ends up back in Louisiana trying to get into Jamie Lynn's house. Again, more bizarre, but not really impaired, doesn't meet 1 through 3. That same guy's got end-stage renal disease and won't go to dialysis because he believes that he's going to live to the same age as Jesus Christ, age 33. Even if he doesn't go to dialysis, we're getting more towards schizophrenia. But if he doesn't have 1 through 3, he's not schizophrenic. The point is that delusional disorder is going to be pretty obvious, and again, on your test, it's going to be a non-bizarre delusion that is completely reasonable, and you're not going to be sure if it's true or not. My wife's trying to kill me for my money. I don't know, is she? Maybe she is. Maybe she's not. But you're going to have to figure out, is it a true delusion? Is it a fixed false belief? Or is it something that's reasonable you need to investigate? If you make the decision that it is a delusional disorder, you're going to need to do gentle confrontation. You need to show them that what they're thinking is wrong, generally because their delusion is going to impair someone else, not that the delusion is going to impair them. I'm going to close this lesson with what you need to know about medications. Choosing the right med. In the situation in which you're going to pick a medication in order to get the test answer right. We're going to cover a lot of detail about Psych Pharm in the Psych Pharm lesson. So I want you to see 4 different scenarios. Someone who's a normal schizophrenic, they want to take their meds, they don't want to have symptoms, they're going to be compliant. Someone who's combative in the ED. Someone who is non-compliant, won't take their meds, but may do well when they're on their meds, they just don't want to take them, so they end up not. And what happens when everything fails? Typical and atypical antipsychotics are called that because typicals were made first. Typicals happen to work on the dopamine receptors the most. They prevent the positive symptoms, and they have a very dirty side effect profile. The more potent, the more severe the extrapyramidal symptoms can be. There's also anticholinergic properties. Atypical means second generation. Second generations generally have a cleaner side effect profile, aren't quite as potent, but work on both dopamine and serotonin, so work on both positive and negative symptoms. If you have your choice, what you should do for a normal patient is use atypicals, the second generation. That's going to be things like quetiapine, olanzapine, and Risperdal. Oral medications, people want to take them, no big deal. A combative patient in the ER is going to need typicals. You're going to need that potency, and you're going to need access to IM or IV. That's going to be found with haloperidol. On the medicine service inpatient, you might find that an atypical is used, olanzapine, dissolving capsule under the tongue. This is the wrong answer. I don't want you to learn it. I want you to know about it because it's used all the time. But if someone's combative, you need to put them down and use haloperidol. The non-compliant patient is going to need a form that lasts rather than once or twice a day pills, or maybe a once a week or once a month injection. To do that, you need the depot forms. And we're coming up with atypical depots, but the depot form I want you to learn about is haloperidol. What I'm trying to do is keep your selection limited. Atypicals for normal, haloperidol for everything else, unless all else fails, in which case you use clozapine. Clozapine was the first of the atypicals, and it was by far the best drug we had. It fixes positive symptoms, negative symptoms, and almost always works. The problem is that it can cause agranulocytosis and patients die. So in order to get it, you have to have tried everything else and get on a registry. Tried everything else means start a medication, your choice. Increase the dose daily until the symptoms go away or you reach a max dose. Doesn't work, stop that, try something else. You keep going until you find something that controls the symptoms. And be on the lookout, we talk about this during the extrapyramidal lesson. Antipsychotics can cause neuroleptic malignant syndrome, which needs to be treated with dantrolene. If you see somebody who's got fever, rigidity, elevated CK, and is on a typical or atypical antipsychotic, think NMS, give dantrolene. This lesson mostly focused on schizophrenia, positive symptoms, negative symptoms, delusions, hallucinations, disorganization. Don't forget about the negative symptoms. Identify that kid who's going to college, who has their first break after a major stressor, roll out drugs. You're going to treat for the duration based on the duration of symptoms, and always is it antipsychotic, unless you get into the presence of mood disorder, in which case you're going to treat the mood first. Delusional disorder is someone who has a delusion, but is not really impaired, and the only reason you confront them is if it bothers someone else. And then in terms of choosing the right medication, quetiapine, olanzapine, Risperdal, essentially equivalent to each other, used in routine cases. Haloperidol IVIM used in the combative patient in the ER, haloperidol depot used in non-compliant patients, and clozapine if all else fails. If you identify NMS, use dantrolene. That is the psychotic disorders.